Very warm welcome to everyone listening this video. Today we'll present a history on nodular swellings in neck and armpits. Mr. Fazil, a 34-year-old man, farmer, non-hypertensive, non-diabetic, non-smoker and non-alcoholic, hailing from Karachi, presents with nodular swelling in both sides of neck and axilla for 3 months. He states that he was reasonably well 3 months back once he has incidentally felt some nodular swellings on his right side of neck, and on searching more he has found swellings also on left side of the neck. As he has no other discomfort, he did not bother it. After a few days he has noticed that swellings are increasing in number and size and also involve his both armpits. He has lost 5 kg weight in last 3 months and he has excessive night sweat requiring changes of night dress. He has no other symptoms like fever, pruritus, cough, sputum, hemoptysis, diarrhea and arthralgia, or any rash and eye problem. He has no history of contact with tuberculosis. He has no significant past history, family history, treatment history, and personal history. On examination, he has multiple discrete, rubbery, non-tender lymph nodes in both sides of neck and axilla, variable in size, largest one in right posterior chain measuring 3 cm in diameter, movable, no overlying erythema or discharging sinus, no anemia, jaundice and bony tenderness, liver and spleen are not palpable, and no other abnormalities. So my provisional diagnosis is lymphoma, most probably Hodgkin's lymphoma. So differential diagnosis, if I put, that is tuberculous lymphadenitis, uh, chronic lymphocytic leukemia and sarcoidosis. Now there can be a lot of discussion over this topic, that why do I consider this diagnosis. A 34-year-old man presents with nodular swellings in both sides of neck and axilla for 3 months. He has significant weight loss of more than 5 kg and drenching night sweats. On examination, he has multiple discrete, rubbery, non-tender lymph nodes in both sides of neck and axilla. No bony tenderness, liver and spleen are not palpable, so I consider this diagnosis. So, another question can be asked, that why do you not consider tuberculous lymphadenitis in this patient? The patient presents with nodular swelling in both sides of neck and axilla for 3 months. He has significant weight loss and drenching night sweats, but no history of fever and contact with tuberculosis or any past tuberculosis. Lymph nodes are not matted and rubbery inconsistency that supports the lymphoma. So I consider tuberculous lymphadenitis as differential diagnosis, not as provisional diagnosis. Another question examiner might ask, why do you think this as Hodgkin's lymphoma? Final diagnosis cannot be reached without biopsy of the lymph node. The clinical features like multiple discrete rubbery non-tender lymph nodes in both sides of neck and axilla, significant weight loss and drenching night sweats, no Walder ring and peripheral lymph nodes such as epitrochlear lymph node, and no hepatosplenomegaly in this patient suggests that probably this is a case of Hodgkin's disease. Now, the examiner might ask that what are the types of lymphoma? Hodgkin's lymphoma and non-Hodgkin's lymphoma. Now, the next question would be WHO classification of Hodgkin's lymphoma. The WHO classification of Hodgkin's lymphoma is nodular lymphocytic, that is predominant Hodgkin's lymphoma. Classical Hodgkin lymphoma includes nodular sclerosing, mixed cellularity or type of Hodgkin's lymphoma, lymphocyte predominant Hodgkin's lymphoma, lymphocyte depleted Hodgkin's lymphoma. So these are four types of the classical Hodgkin's lymphoma: nodular sclerosing, mixed cellularity, lymphocyte predominant, lymphocyte depleted. So the examiner might ask that classify non-Hodgkin's lymphoma. The classification of non-Hodgkin's lymphoma, it includes high-grade tumor and low-grade tumors. Now, how can you differentiate Hodgkin's lymphoma from non-Hodgkin's lymphoma? This is another question. So there are a lot of differences between Hodgkin's lymphoma and non-Hodgkin's lymphoma. The Hodgkin's lymphoma, the lymph nodes are localized to single axial group, while in non-Hodgkin's lymphoma, peripheral lymph node involvement is common. Mesenteric lymph node and Walde's ring are commonly involved in non-Hodgkin's lymphoma, while in Hodgkin's lymphoma, there is no Walde's ring involvement or mesenteric lymph node involvement. Number 3 is the difference between Hodgkin and non-Hodgkin is lymph node spread. In Hodgkin's disease, there is orderly spread by contiguity, while in non-Hodgkin's lymphoma, there is non-contiguous heterogeneous spread. Consistency of lymph node in Hodgkin's disease, it's rubbery, while in non-Hodgkin's it is variegated or firm lymph node involvement. The consistency is firm. Extranodal involvement in Hodgkin's disease is less common, while extranodal involvement in non-Hodgkin's disease is more common. The systemic features is more common in Hodgkin's disease. Bell-Epstein fever, it may occur in Hodgkin's lymphoma, while it does not occur in non-Hodgkin's lymphoma. Pruritus is common in Hodgkin's disease. Reed-Sternberg cell on histology, and prognosis in Hodgkin's disease is high cure rate, while in non-Hodgkin lymphoma there is low cure rate. The examiner might ask, how will you investigate this patient? Full blood count with ESR, lymph node biopsy, chest x-ray, PA view, ultrasonography of abdomen, CT scan of chest, abdomen and pelvis, bone marrow aspiration, trephine biopsy, liver function test, and other tests like PET scan, gallium scan, and SPECT. What are the expected findings in full blood count in a patient with Hodgkin's disease? Normocytic normochromic anemia, eosinophilia in 15% cases in Hodgkin's disease, lymphocytopenia, that is, it is associated with a bad prognosis. Leukemia reaction may occur, common in Hodgkin's disease. What is the importance of ESR in lymphoma? That is another question. ESR is the best indicator of disease activity. High ESR indicates disease activity. What is the confirmatory investigation for diagnosis of lymphoma? For lymphoma, we take lymph node biopsy, while if we suspect leukemia, then lymph node biopsy is contraindicated. Another question, that what is the hallmark of Hodgkin's lymphoma? Reed-Sternberg cell is the hallmark of Hodgkin's lymphoma. Presence of Reed-Sternberg cells confirms the diagnosis of Hodgkin's disease, but absence of Reed-Sternberg cells does not exclude Hodgkin's disease. What are the characteristics of Reed-Sternberg cells? Reed-Sternberg cell is a giant cell which looks like owl's eye and characterized by large cell with abundance of acidophilic cytoplasm, mirror image nuclei with vesicular pattern, chromatin is loosely woven, and multiple nucleoli with perinucleolar halo resembling owl's eye appearance. Now, what are the other conditions in which Reed-Sternberg cells are found? Other conditions in which Reed-Sternberg cells are found, it includes Hodgkin's disease, infectious mononucleosis, Burkitt's lymphoma, malignant melanoma, breast carcinoma. Another question, how is the clinical staging of lymphoma done? Clinical staging is, there are 4 stages of lymphoma. The stage 1, involvement of a single lymph node. Stage 2 is involvement of 2 or more lymph node regions or an extra lymphatic site and lymph node region on the same side of the diaphragm. Stage 3, involvement of lymph node regions on both sides of diaphragm with or without localized extra lymphatic involvement or involvement of the spleen or both. Now, stage 4, a diffuse involvement of one or more extra lymphatic tissues, for example liver or bone marrow. Each stage is subclassified into no systemic symptoms, that is absence of B symptoms, or presence of B symptoms. Now, what are B symptoms? Presence of fever above 38 degrees centigrade, drenching night sweats, unexplained weight loss more than 10% in the previous 6 months. What is the significance of B symptoms? Presence of B symptoms indicate bad prognosis. Now, what is the stage of this patient clinically? I would say that is the stage 2B, as lymph nodes involvement is on one side of diaphragm, that is above the diaphragm, and presence of B symptoms, that is weight loss and night sweat, although there is no fever. So it is stage 2B. What are the lymphatic structures? The lymphatic structures are defined as the lymph node, spleen, thymus, Waldier's ring, appendix, and Peyer's patches. The examiner might ask, what are the patterns of fever in lymphoma? Fever is usually low-grade fever without chill and rigor. Fever may be remittent or continued in type. Occasionally, swinging fever with sweating occurs. The classical Pell-Epstein fever occurs in Hodgkin's disease, but it is not seen nowadays. It is a cyclical or a periodic fever where several days or weeks of fever alternate with a febrile period. What are the other causes of Pell-Epstein fever? It includes brucellosis, hypernephroma, as well as Hodgkin's disease. The examiner might ask, what are the causes of anemia in lymphoma? So there are four causes of anemia in lymphoma, that is ineffective erythropoiesis, the bone marrow infiltration by the lymphoma, hemolysis, autoimmune hemolytic anemia, hypersplenism, hemodilutions. What are the causes of jaundice in lymphoma? Number one is the lymphoma cells involve the hepatic architecture, the hepatic involvement, compression at porta hepatis by lymph nodes, hepatitis due to repeated blood transfusion, and hemolysis, like autoimmune hemolysis, occurs in lymphoma. Another question, that how paraplegia is produced in lymphoma. Paraplegia may be produced by one of the following mechanisms, that is involvement of body of the vertebra with collapse. Involvement of thoracic vertebra is very common in lymphoma. Invasion of the epidural space from retroperitoneal lymph nodes with cord compression, and disruption of vascular supply of the spinal cord. So another question, that what are the modalities of treatment of Hodgkin's lymphoma? It includes radiotherapy, chemotherapy, and combined both radio and chemo. So what are the indications of radiotherapy in Hodgkin's lymphoma? Well, radiotherapy is indicated in stage 1 and stage 2A disease. Radiotherapy is also given after chemotherapy to sites where there was originally bulk disease, and radiotherapy is also indicated in case of lesions causing serious pressure problems. What are the indications of chemotherapy in Hodgkin's lymphoma? Well, all symptomatic patients, that is all stage B patients, stage 3 and stage 4 patients, they are also candidates of chemotherapy in Hodgkin's lymphoma. While in stage 2A, if there is more than 3 lymph node involvement, it's an indication of chemotherapy in Hodgkin's lymphoma. How will you treat this patient? What is the chemotherapeutic regime in Hodgkin's disease? As our patient is in stage 2B, the chemotherapy includes ABVD regime, that is doxorubicin, bleomycin, vinblastine, dacarbazine regimen every 3 to 4 weeks interval for a total of 6 to 8 cycles. How will you check the treatment response in case of Hodgkin's lymphoma? Treatment response is assessed clinically and by repeated CT scans. And what are the prognosis of Hodgkin's lymphoma? The prognosis of Hodgkin's lymphoma depends upon which stage the patient presents. Stage 1, 85 to 95%, 10 years disease-free survival, while stage 2 is 80 to 90%, 10 years disease-free survival, while in stage 3 and 4, 60%, 10 years disease-free survival. Another question, that is, what is the treatment of non-Hodgkin's lymphoma? So non-Hodgkin lymphoma are divided into low-grade non-Hodgkin lymphoma and high-grade non-Hodgkin lymphoma. For low-grade non-Hodgkin's lymphoma, radiotherapy, chemotherapy including chlorambucil or anti-CD20, that is Rituximib, in combination with cyclophosphamide, vincristine, and prednisolone. Transplantation, high-dose chemotherapy, and autologous hematopoietic stem cells transplantation. While High grade non Hodgkin's lymphoma, the chemotherapy regime includes R-CHOP, that is Rituximib, cyclophosphamide, doxorubicin, vincristine, and prednisolone. CHOP or R-CHOP in high-grade non-Hodgkin's lymphoma plus radiotherapy and plus autologous hemopoietic stem cell transplantation. So this was our discussion. Now examiner may ask that what are the causes of generalized lymphadenopathy. So generalized lymphadenopathy, the lumps and bumps, the causes are lymphoma, leukemia, ALL, CLL, infections like tuberculosis, brucellosis, toxoplasmosis, infectious mononucleosis, HIV, sarcoidosis. SLE can present as generalized lymphadenopathy, phenytoin, diphenyl chronic lymphocytic leukemia, CLL, and sarcoidosis. These are the some of the causes of generalized lymphadenopathy. Thank you very much.